so many cases of perforation peritonitis. So Apache is a commonly used prognostic system, but we did not have blood gas and arterial pH. So we simplified it by using only 5 or 6 commonly available parameters. We called it Jabalpur prognostic scoring system by the name of my place. And we have had 2 decades, more than 30 postgraduate MS theses have been conducted on this. More than 7-8 publications are on this other than mine. And it's an established scoring system which is widely being used in India. We similarly simplified Burns scoring system. We also call it Jabalpur prognostic scoring system. About 5 to 8% of our peptic perforations, they leak. The momentum is already gone. The adhesions take care that we cannot put a jejunal serosal patch. We thought, why not put in a rectus abdominis myoperitoneal flap? It's locally available and very well vascularized muscle. So that is what we did. Our residents were struggling with upper outer quadrant sutures. So we simplified it. We asked the anesthetist to push the nasogastric tube, and we tied the flap to the nasogastric tube. And once the anesthetist pulled it back, it went and plugged. It became a plug. So it became so easy that even my young residents can perform it. We still get plenty of cases of typhoid perforations. Our mortality rate was 30%. Any patient who leaked after repair or resection resulted in a fecal fistula died. Every patient. We didn't have TPN, we didn't have ICU care. So what we did was we started performing defunctioning ileostomy in every patient. And our mortality rate came down to less than 3%. Such a simple idea. Even today, we don't have a stoma care therapist. So they all teach each other when they are in the ward. They come back after 3 months for closure of the ileostomy and everything becomes all right. Such a simple idea. Now, one of the patients came back with such beautiful shiny skin. I asked him, what are you applying? He said, I'm using linseed oil. I said, what? He said, linseed oil. It has medicinal property. I didn't know that linseed oil could be used as a medicine. Once I looked it up, the history of mankind, in the history of civilization, every generation has used linseed oil for its medicinal property. I'm very happy I learned it from one of my patients. The cost is 1/10 of the commercially available ointments, and it is highly acceptable by rural patients because they have been told by their grandmothers that linseed oil has medicinal property. Simple idea. We have our own technique. We use a stripper for our transhiatal esophagectomy patients. Earlier, when I was putting my hand in the region of the middle part of the esophagus, transhiatal esophagectomy, the anesthetist will keep shouting at me, you are pressing the heart, the venous return is going down, the blood pressure is falling. So we devised this stripper, which is introduced from the neck, and the normal part of esophagus is taken care of in less than 1 minute. So we mobilize only the lower 1/3 where the malignancy is by transhiatal dissection. Everything else takes 1 minute. So we don't have staplers. We have our own technique of devascularization of portal hypertension when we give transmural sutures. And for very low anterior resection in females, we deliver the rectum through the perineum by perineal incision and do the anastomosis after finishing the TMRE from below. Under vision, everything can be done from below. For a skin grafting patient, when I was young, I was told that if there is anemia less than 10 gram%, don't put in a graft, it will not take. We have shown that even at 6 gram%, normovolumic anemia, the graft will take. We had a project on cadaveric allograft. The rejection time was about 2 weeks. We thought, why not remove the epidermis, graft only the dermis, because all antigenic elements, they are in epidermis. So the rejection time increased to 4 weeks. Such a simple idea, just remove the epidermis. Everyone knows that Carroll got the Nobel Prize for vascular anastomotic technique in 1912. And he made the science of organ transplantation possible. And he learned it from his mother from tatting and knitting. So we went back to the books of tatting and knitting. We learned a very simple extracorporeal knotting technique, which my residents and younger consultants use. And we also learned that herringbone suture for abdominal facial closure is possible. As you can see, herringbone closure is stronger than over and over suture. So our incisional hernia rates have gone down. We don't have auto transfusion equipment, so we just collect the blood in a drainage bag, add heparin, turn the bag upside down, and use it for auto transfusion. For pediatric surgery simplification, large hydrated cyst, we don't open the abdomen. We give a simple incision, single incision, right over the hydrated cyst, put in the scope, and do the surgery, trocarless hydrated cyst surgery. In the same vein, for anorectal malformation, sigmoid colostomy, first stage was being done in the left iliac fossa. And then in the second stage laparoscopic surgery, this came in the way, and it was ergonomically more difficult to first take down the colostomy and then perform the surgery. So we shifted from here to here. The sigmoid colostomy shifted, lateralized the colostomy, and for the second stage surgery, everything is free, left iliac fossa. In selected patients of anorectal malformation, if the sac is low, then a transperineal intracath can be introduced and meconium can be irrigated and removed. So in selected patients, single stage surgery is even possible. So such a simple idea. For young children, female children who had external angular dermoid, they did not want an incision here for cosmetic reasons. So how will the girl get married if she has a prominent incision here? So that was the requirement from the parents. So we introduced it from the hairline, and from the hairline, it was possible to do subcutaneous scopic excision. For strangulated hernia, we get plenty of these cases. We have shown 5 years ago that Prolene mesh is very much safe and it is feasible. Just we have to make sure that the mesh is placed flat. These large macroporous meshes, what they have 120 micron pore size. The bacteria and the granulocyte, they are able to cross easily through the pores, and it is possible. It is possible even for perforation peritonitis in selected patients if we want to provide prophylactic mesh after surgery. I don't know if you are aware of a disease called Burgess disease, thromboangiitis obliterans. Because of tobacco, and small and medium-sized arterioles are affected, and the block is multi-segmental. So bypass is not possible, stenting is not possible, and all of them have severe pain because of tobacco smoking. You can see, and we usually perform lumbar symplectomy in an attempt to increase the blood vessel, the blood flow. Sometimes omental transposition is also done, but they end up losing, sorry, just 1 minute. And they end up using toes and even limbs. So we started injecting platelet-rich plasma taken from the patient. Our blood bank, it centrifuges the blood and gives us PRP. PRP are the storehouses of growth factors. We just inject them all around, and within 2 weeks, ulcers heal. You can see such a big ulcer. It has undergone lumbar symplectomy, omental transposition. Even someone had tried skin grafting. It started healing after injection of PRP. Such a simple thing possible even in a district hospital. Some of our patients who come after paraplegia and they have a contractile bladder, they cannot evacuate their bladder. So the treatment earlier was either continuous catheterization or intermittent self-catheterization. In both the cases, the risk was ascending infection, cystitis and ascending infection. And within a couple of years, they'll have severe infection and even death will take place. So what we did was, we are quite familiar with the rectus abdominis muscle because it has very good blood supply, dual blood supply from the top and from the below. We'll cut from the top along with its blood vessel, dissect the bladder and wrap the rectus abdominis muscle like a turban around the dome of the bladder. And after 2 weeks, when the catheter is removed, patient is asked to contract the rectus abdominis muscle and he can pass urine. My house surgeon is asking patient to strain from the rectus. See such a good flow. Good flow, and over a passage of time, the residual volume goes down below 100 ml. we have too many patients of Hansen's disease. Unfortunately, we are the capital of Hansen's disease in the world, more than 100,000 new patients. And they lose the sensation of the foot and they keep on getting injured again and again and again. They have what is known as trophic ulcers. So what we realized was that it is the posterior tibial nerve which loses its function, but the saphenous nerve is intact, which supplies the medial part of the sole. So all it required was transfer of the saphenous nerve at the level of ankle to posterior tibial nerve. And over a period of 3 to 6 months, the neurotization took place, the sensation started appearing, and as a bonus, the trophic ulcers, they heal. So it is the gift of the pain. Once the patient have pain, they can save their own feet. We applied the same thing for selected patients of diabetic foot, and now we are in a position to change the natural course of disease for both these diseases, for Hansen's disease as well as for diabetic feet. So many simple ideas for maxillofacial wiring. Instead of wiring, we started using rubber bands. These rubber bands are made from the injection port of infusion. They can be cut and they can be applied. The wiring can be done with these bands. The advantage is if the patient has vomiting, has some element of head injury and starts vomiting in the middle of the night, most of our surgical wards don't have the cutters to cut the steel wires. But these rubber bands, indigenous rubber bands, can be cut easily by an ordinary scissor, and they are practically free. They can be reapplied next day in the morning. We didn't have a biopsy gun for our breast lumps, so my young residents and young lecturer, they devised one biopsy gun by combining a 50 ml syringe with a 10 ml syringe. By combining the two, enough suction was produced and they can get a good biopsy specimen. Cost not even $5. So for our sentinel lymph node biopsy, we don't have frozen section. We are very happy to see that imprint cytology works as well. We don't have vessel loops, so we just cut the gloves like this and use them for vessel and tendon loops. About 5% of our peptic perforations are very large, more than 2 centimeter size, and their leak rate was much more. So we thought, why not combine plug with patch? So we make 2 flaps of the omentum. One flap goes in as a plug, the other one is applied as a patch. So in more than 20 cases, the leak rate has been 0, and we have published it recently. So it is just like double protection, wearing a belt as well as suspenders, both double protection. So this is our word cloud for the work which we do, and this has allowed us to produce more than 100 publications on affordable surgical solutions. When I started doing my master's in surgery, initial few years, I gained my identity by mastering routine operations. But I realized that I have to simplify these procedures, and I gained a different surgical personality by simplifying these operations. And it has been a very wonderful, rewarding journey. So many honorary fellowships from France, from Thailand, all the fellowships from UK and Ireland, and so on. So many guest lectures and honorary professorships all over the world. Very rewarding journey. So I'm usually asked by young surgeons, what do I recommend? How do we go about finding these solutions? So we learned many lessons along my life, and some of them lessons are from giants on whose shoulders we are standing. We all learn from our predecessors, and some of the lessons have been hard lessons which I learned myself. So I'll be happy to share them with you. Rule number 1 is always get permission from the ethics committee. Always, always. Remember, it may appear harsh when they refuse a permission, but they are for patient safety as well as my safety. And we are not cowboys. Do I look like this? I wish I looked like this. I don't look like this. We don't shoot from the hip. No. So if the passionate are doing the surgery, the skeptics have to be in charge of the ethics. So when they reject my proposition, I go back to the lab, I go back to the anatomy department, refine my presentation. So after 3 months, when the next meeting takes place, I'll try to convince them again. Rule number 2 is every difficulty is an opportunity. Very few surgeons have received Nobel Prize. The last one to receive was Professor Joseph Murray. And this was the plaque on his table. So we learned from him, every difficulty is a challenge. And some of the challenges we have been able to find a solution for, which I am sharing them with you today. Next rule was we'll do research on what is important for us. It is very easy to keep on waiting for doing research on what interests you. When I was young, my dream was to perform a cardiac transplantation in the morning, go back home, have my lunch, come back in the afternoon and find a vaccine for cancer. I think this is how young people dream, wildest of dreams. And what did I land up with? Perforations, gangrene, no ICU, sometimes oxygen running out, and so many issues. So I have to do research on what is important for me. And this comes from Alan Heeger, another Nobel laureate, that you have to do research on what is important. This was the rule I made 17 years ago, the first day I became the head. No whining, no complaining. I don't want anyone to come crying on my shoulder. This is not available, that is not available. You knew about it when you joined the work in a medical school in India, and you have to come with solutions. So my urologist came crying that I don't have a TUR scope. I said, donate one. He's a rich man. Urologists earn a lot. So he donated one. I said, you are going to use it. So he donated one and he started using. And later on, when the opportunity came, we were able to buy one cystoscope for him. Similarly, my plastic surgeon said, I don't have a operating microscope. I said, donate one. Plastic surgeons are also very well off. So he donated one, which he and his team were using until we were able to buy. So I ask my boys and girls, please come with a solution. Don't just come and cry on my shoulder. This is not available. That is not available. Try to find how we can arrange that, whatever resource you are crying about. So this became a key for us. Modify, simplify, and apply. This is what we do. I am very fond of Occam's razor. I don't know if you know about this. Occam was an English philosopher, and more than 500 years ago, he came out with his hypothesis. If there are many explanations for any phenomena, the simplest one is likely to be the most correct one. So we are trying to find the simplest solution. Usually it is the most economical one. So that is what we try to do: simplify, modify, and apply. And when the solution is simple, God is answering our prayers. And simplicity is the ultimate sophistication. That is what we are aiming for. Next rule was, we'll not discuss people, we'll not discuss events. We are scientists, we'll only discuss ideas. It's very common for young residents to talk about film stars, movie stars, sportsmen, politicians, and they while away their time discussing these people who are usually selling them something in the form of an advertisement. So again, this idea comes from one of my favorite Nobel laureates, Marie Curie, who only person till today who got the Nobel Prize in 2 science subjects. And she said, let us be more curious about ideas. And why not? Why not? It is within our reach to find our own solutions. We have to find our solutions. Let us discuss only ideas. And we have to keep an open mind. So many ideas come. So unless we'll keep an open mind, we'll not be able to grab the good idea. Noble thoughts are coming from all sides. Rabindranath Tagore is our first Nobel laureate from India more than 110 years ago. He was not allowed to travel by the English to receive the Nobel Prize in Stockholm. He said, noble thoughts are raining. Literally, they are raining. And since we have the lived-in experience, the idea is usually right in front of us. We just have to keep our mind open and we'll be able to see it. We should not be like this person who has an umbrella and a mental block who is not able to see simple solutions. Next rule was have many ideas. Again, a Nobel laureate, but science plus peace. And what did he say? If you want to have good ideas, you must have lots and lots of good ideas and just learn to recognize which is good and bad and throw away the bad ideas. So we keep on talking. Sometimes the ideas are good. Sometimes the ideas are not so good, but we try not to say it on the person's face that you have a poor idea. We just tell them, okay, let's see. Can we have something better? Can we have something better? And ideas are, daring ideas are like chessmen moving forwards. An ordinary chessman may be sacrificed, but anyone who plays chess knows that if the chessman reaches the end of the board, he becomes the all-powerful queen who can do anything. So maybe some idea may be not very successful, but it can start a chain and it can start a winning game. So this is what we try to do, have plenty of ideas. And how to recognize a good idea, that's the key. Newton had shown us that opportunity favors the prepared mind. You think the apple had fallen for the first time in the history of mankind? No. But Newton was able to recognize it for what it was and came out with the law of gravity. So often it happens that we have our idea while we are mulling over it, someone else publishes it. We all see similar patients. We all see similar textbooks. If you don't recognize a good idea, someone else publishes it. Don't cry. It's your fault. So you have to recognize and go ahead immediately. Next rule which we made was we have to develop an innovation ecosystem. So like Professor Derais had asked me about our department, how we progressed, this is what we did. It's a general surgery department. We have no silos. Pediatric surgery, plastic surgery, urology, GI surgery, everything. We all sit together in the operating room in between two cases over a cup of tea or coffee. There is a lot of cross-fertilization of ideas. As you have seen, a couple of ideas we have borrowed from our pediatric surgeons. Some idea were from our plastic surgeons. There is a very good team spirit and very healthy sibling rivalry. So if some unit publishes a good paper, they have to pay for the cup of tea that day in the operating room. And if they get a rejection, some good paper, so they get to cry on our shoulders. So I'll pay for the cup of tea that day. So we celebrate each other's successes and mourn each other's failures. And this is my job. Young, fertile minds, young minds are the most fertile. If you'll go back into the history of Nobel Prize, most of the Nobel laureates got their Nobel Prize on the idea which they had in their 20s and 30s. They kept on pursuing that idea, and finally it became a success and they got the Nobel Prize. So young minds are fertile. I have to protect them from a lot of things are going on in an academic institution which are not very helpful. Sometimes there is rivalry, sometimes there is a strike, sometimes the salary doesn't come on time. I have to protect my young boys and girls from all these things. So that is my job, my role, that of a Chief Innovation Officer, CIO. My job to see everything runs, and I still work 20 hours a day. And we generate a lot of ideas. I tell my young boys and girls what will happen when I will retire. So why don't you people start producing more and more ideas? So it is exactly 5 past midnight in the night here. I'm still at my work. I have not finished for the day. So that is my role, pushing the department. Do more, I want more, you are capable of more. That is my job. Finally, we don't talk about an idea unless we publish it. We don't want anyone to steal our idea. So we walk the talk, we publish and then we talk. That is what our aim is, and that is what we do. Everyone talks about value for money. It's a very, typical thing to talk about. Value for money. You buy a telephone, you want so many GBs of data storage. Camera should be like this. I talk about value for money. That is what affordable surgical solutions bring on the table. This is what people who have been denied everything, people who are beyond anyone's reach, we want to provide value for them. This is our mantra, because to lead is to serve, not to rule. And we have to do it. We don't have to do it condescendingly. We have to do it graciously. That is what I teach my boys and girls, because we have yet to provide equitable health needs for everyone. And that is the last battle of democracy which we have to do. And it has to be a fruit of collective efforts. And if you agree with me, please join hands with me from across the world. Please join hands with me. I can see you guys. Please join hands with me if you agree with me. Thank you very much.
Well, thank you so much, Professor, for that wonderful talk. It resonates in many, many ways, at least with my career and what I've seen. And I suppose those of us who have been around a while have had the opportunity to see most of the principles that you are talking about. But one of them that I think a lot about in the United States is the idea of simplifying. When I speak with my biomedical engineers, and for the students in the room, those people are usually located in the basement, and they are the people who fix the stuff that we use, all kinds of stuff from intravenous drips to all of the equipment. And it's well worth a visit to go on down, because they're always delighted to show you what it is they do, how they fix it, and what are their frustrations with what we do with the equipment in the operating theater, and also on the wards. But I've asked them several times. Well, I like to ask them everywhere I go, actually. I like to poke around closets and also ask the people who are doing the sterilizing of equipment, the sterile process people, and also the biomedical engineering people. And the first thing that I heard that has always stuck with me, but you repeated it again, Professor Sharma, is about simplicity. The thing they hated most was the IV drips, because in our hospital, they are so complicated that often they cannot be repaired. They have computer chips in there that often cannot be repaired. So something that should be able to run fairly simply. Now, there are times in the intensive care unit where you might need something a lot more complicated, but the IV drip should not be that complicated. And it has gotten so complicated that it can't even be repaired. So I think about these things a lot, and I'm wondering how many of the people in the room in Helix there that I'm seeing have been down to biomedical engineering and have actually talked about the equipment that we use even in the University of Utah. I'm not seeing a very big picture, so I can't quite tell, but I encourage you to do this. And the idea of the ecosystem is fundamental to working and innovating and rethinking how we work together. I love your talk about silos and how we very often break into our specialties early on in the training in the United States. It can be as early as internship or right after medical school. And from there on, you don't go back. And that cross-fertilization of ideas is so critical. So I'd like to open it up, though, to students and anybody else who is on the video for questions, since we have Professor Sharma and he's awake past midnight. we want to engage him as much as possible. Liz, there you go, unmuting it. Questions from the groups?
Questions, comments, I'll be very happy to share my thoughts.
Yeah, here we go. Can you hear me okay from the room?
Yes, go on, please.
Dr. Jayaraman, sorry I was late. I was stuck in the operating room, and I have another patient who's about to go to sleep for my next case. So I thought I'd come by for 20 minutes. So I caught a little bit of your talk. Thank you so much for sharing your evening with us. What advice do you think we should be sharing with our next generation of trainees, to try to keep all these ideas, because when you come into medicine, you have a lot of ideas because you don't really understand how things work, and you learn all these different things, and then you narrow. How would you suggest that we get the next generation to stay and keep that naivete? Because a lot of those great solutions come from seeing things for the first time and asking, well, why is it this way? This doesn't make any sense. Whereas those of us who have been thinking about it for decades, we only know one way to think about it anymore. And we never question that underlying, like, this is the way of doing it. Does that make sense?
My answer actually has two parts. I encourage my residents to voice whatever question they have, and I equally encourage my consultants to listen to the resident. It should never be brushed aside. And up till now, we have had what is known as eminence-based practice. Just because a professor has been doing the hernia this way, that doesn't mean that the surgery will not move forwards. So now we are in the era of evidence-based. So I'll encourage the young resident or the intern to actually voice whatever question he had. But before that, perhaps do a bit of homework. Just check the basics, the anatomy, the physiology, the pathology, whatever. Just check the basics of that idea, and he should not be shy in expressing it. And the consultant should not take it as an affront that why my process is being questioned. So does that answer your question? That discussion has to be encouraged.
Yeah, it's a two-way street to both come up with the questions and come up and be allowed to question. And you know, in a hierarchy in surgery and in medicine, that dissent and questioning attitude is often not encouraged. How would you encourage the faculty, the consultants? What do you tell them to keep their minds open? How do you tell them to be humble when the more junior folks have come up with ideas?
Prof, I'm very, very lucky. Almost everyone in my department, I have 26 consultants. Almost everyone has been taught by me. So they know my philosophy. Right from the time when they were residents, they were sharing their thoughts with me. So I'm that way very lucky. And most of them have inculcated this, that they encourage their residents to share their thoughts. And it's a close-knit department, very close-knit department. All of us sit together, and this is what we are discussing. We don't want to talk what is happening outside our operation theater or outside our department. I don't encourage that. I encourage them to discuss only ideas. So this is what we discuss all the time.
Other questions? Dr. Rockwell?
Yes,
Yeah,
Professor
sure.
Sharma. It was a great talk. I'm Brad Rockwell from Plastic Surgery. In a very short time, you presented many great ideas, and I'm sure there was a lot of work behind it and a lot of thinking and a lot of unsuccess in order for you to reach your success. I was interested, the idea you gave of wrapping the rectus muscle around the bladder to allow someone to empty their bladder. How long from first idea to successful surgery?
2 weeks. 2 weeks. It is already there in the latest textbook of urology, Campbell's Urology. It is accepted and it has been published in the latest issue of Campbell's Urology.
Yes, but from someone having an idea to wrap the muscle around the bladder to figuring out how to try it, and I assume the first trial
it was
some result, then you modified.
It was in cadavers. First, we tried it in cadavers, and once we realized that we can do that, then we selected patients very carefully, and then we started doing it.
Excellent. And is that a procedure how hard is it to get it through the ethics committee? Say
That
doing
is
an
the toughest-
operation that
Yeah.
no one has done.
Two things which are toughest. Innovation is the easy part. Two toughest things for me, first is getting it past the ethical committee, and second most difficult part is its dissemination and adoption by others. Innovation is the most easy part.
Yeah.
So I'm wondering about what you do when you're using human subjects like this, because in our place, you would often have to go through an animal lab and prove that it works in animal studies
Yes.
before you're able to do this
Yes.
in a
Yes.
human.
Fortunately or unfortunately, we are not allowed to have animal labs anymore. We had one of the ministers, and about a couple of decades ago, she was animal rights fanatic, and animal labs have been banned. So we have only the cadavers in the anatomy department, and sometimes in the postmortem room when we take permission from the patient's relative, and we are allowed to do certain modifications in our surgery.
So that might work with the anatomy part, but the physiology of it and the dynamic aspects of it, you would then need to have a conversation with a prospective patient.
Yes.
That it would be the first time that it
Yes.
was actually tried, and that
Yes.
patient would see the benefit based on
Yes.
the anatomical studies and your knowledge of how the rectus would work
We-
when wrapped around the bladder. As a urologist, I'm interested in this particular
Plastic surgeons are very familiar with the rectus abdominis flap. They are very confident, and it has dual blood supply from superior and inferior epigastric. So they are confident that it will go where they want to take it. Plus, they are equally sure that it should function also. So that is how the idea evolved over a cup of tea, and it has reached fruition. I'm very happy to share that idea. And you have a plastic surgeon sitting in the audience. We are very lucky if we expand our 2D vision to 3D. Plastic surgeons have 4D vision. So hats off to all the plastic surgeons. They are the smartest guy in my department.
I have a question about minimally invasive surgery.
Dr. DeVries, can I just make one quick comment?
Oh,
I have to
yes.
go back to the operating room because my next patient is going to sleep now. So I'm sorry I have to run. And our students here in the audience may peter out because they have class in a few minutes. So some of the conversation will be the online folks. So just keep that in mind. It's no offense to you. It's just that they have to get to class on time. Otherwise they get yelled at. So and I unfortunately have to go to my next case. But I really enjoyed this discussion. I'll leave our other colleagues to continue the discussion in my absence. Thank you, Dr. DeVries.
Thank you so much, Dr. Jayaraman. And I guess my question is about minimally invasive surgery, and how do you find that to fit into your low-cost model? And the transition to robots, for example, in the United States has become almost so universal that even the trainees don't know how to do the basics of open surgery. They go direct to robots, and if you ask them to do an open operation, they won't have had experience by the time they finish training.
Ma'am, we are lucky we haven't reached that. We don't have to answer that difficult question. Most of the surgeries are still open, and some units have taken the laparoscopic surgery to the advanced level, but most of the other units, our pediatric surgeons are doing a great job because they were the first to acquire a lap set, and other units are playing catch up. We are doing gallbladders, ventral hernias, appendicectomies, inguinal hernias, but colectomies and bigger operations, they are still not being practiced regularly. So we are still doing quite a number of operations in an open technique. Most of the hernias are still being done by open technique because we want our residents to get sufficient hands-on training. If all hernias will be done by laparoscope, then they'll not get their chance. So few surgeries like emergency laparotomies, hernias, mastectomies, and open gallbladders and thyroid surgeries, small thyroids, we make sure the residents get enough cutting work before they leave, so they are reasonably confident when they leave the department.
Thank you. Do we have questions from?
I had an occasion about 13 years ago to visit Rochester, and I called on Professor Schwartz. You remember Professor Schwartz?
You mean Schwartz of the book Schwartz?
Yes.
Yes, that Professor Schwartz, of course.
Yeah. So he was talking about the cost and the training involved in robotics. 2010, I was in Rochester, upstate New York. And he said, do you face this problem? I said, no, thankfully, no. He said, the cost of the machine is mind-boggling for me. I said, I can't even imagine the number of zeros which are there in that. But now in India, there are many centers who have robotics, and some of them are doing very, very well. Very well.
Thank you. Do we have questions or thoughts from other members of this?
Yeah, I have a follow-up questions on the previous questions that has been asked. First of all, thank you very much for a brilliant, really brilliant talk. And second, I'm just an intruder. I'm not a surgeon. I'm actually in the neuro rehab, and I enjoy joining this group and learn all kind of stuff. And today is really special, so thank you. My follow-up question is regarding the wrapping of the bladder with the erector muscles. I'm curious to know how many procedures you have done so far. And
around 10.
The success rate?
10.
What is the success rate? Is it working for everyone or so far? Or
Yes.
cool.
Male and female?
Male patients mostly. They have these problems because of industrial accidents.
Right. So I imagine those are mostly spinal cord injuries.
Yes, young patients in their mid-30s.
Okay. Does it matter the level of injury, the spinal injury?
Yes, it does. Actually, if we talk about the quality of life, we have conducted a study on these paraplegics, and number of things which are important to them is their independence. In being able to void is one of them. If they are able to void, it makes a big difference to them.
Okay.
And the rectus abdominis is not very important to them because they are, they are bedridden.
Right.
So that we can, even if we take away one rectus, there is no herniation. And if they are able to void, it's a plus win-win situation for us.
Okay. So the empty, when you says all of them are successful, I'm assuming all of them, they recover some capacity of.
Yes, they are able to void urine. Yeah, they are able to void urine.
How about the ascending infections? Is there still some occurrence of that, or that also?
No. They don't need catheterization anymore. That is the most important point.
No, I know, but is there any secondary infections after the procedure? Okay.
No, the residual urine amount over a period of 6 months goes down below 100 ml.
Okay. Cool. Thanks again.
My pleasure.
Well, thank you so much. I think we can wrap it up now since we don't have additional questions, but I want to thank you for staying up and sharing with us that wonderful talk.
It's my pleasure, ma'am.